Assalamu alaikum and good afternoon. My name is Asif Loya. I'm a pathologist by profession, and I'm also the medical director for Shaukat Khanum Memorial Cancer Hospital and Research Center in Lahore. I welcome you all to the Ahsan Rashid Memorial Medal Session. This is the most awaited and the most prestigious part of this whole symposium, especially for the trainees. It's awaited, and I know that some people actually prepare the entire year for this event. And they keep rehearsing till the very end so that the presentation is the best out of all the ones that we have. Let me tell you a bit about Mr. Ahsan Rashid. Mr. Ahsan Rashid, he was a great supporter of Shaukat Khanum Memorial Trust, a very good friend and a very close friend of Mr. Imran Khan, both in philanthropy as well as in politics when it all started. Very popular figure amongst the Pakistani expatriates in the Kingdom of Saudi Arabia. He helped Shaukat Khanum a lot while the funds were being raised to start and to construct the Lahore hospital. He was very well known for his compassion and generosity. Unfortunately, he succumbed to cancer himself towards the end of 2016. And it was in 2017 that we decided to start this medal session in his memory. And this medal is awarded to the highest ranked research, which is presented and is judged by independent judges and who decide as to who is amongst all the presenters the winner. So we will have some more awards to give away as well, and I will tell about those awards as we move on. So I think we should get started with the Ahsan Rashid Memorial Medal session. I would like to call the judges on the stage, please. First of all, Dr. Mansoor Bangash. He's a consultant in anesthesia and critical care, and he's an honorary senior clinical lecturer, School of Clinical Sciences. He's also the chair for Birmingham Liver Failure Research Group. Dr. Mansoor Bangash, please, if you could come on the stage. Next, Professor Iftikhar Qayyum. Professor Saab is a director of research and is the acting director for medical education at the famous Rahman Medical Institute in Hayatabad in Peshawar. Professor Saab, please come on the stage. And last but not the least, our very own Dr. Faisal Sultan, who's the Chief Executive Officer for SKM Trust. So today we have 6 presentations. I must tell the rules that the time allotted for presentation is 8 minutes, and then there'll be 2 minutes for questions. I would request all the presenters to please mind the time, because that actually does go in deciding and as a deciding factor as well. One of the deciding factors, besides many others, obviously, that the judges have. So without further ado, I'll call the first presenter, and that is Ms. Sidra Mumtaz from Government College University Hospital in Lahore, Pakistan. This would be a virtual presentation, and she would be talking about MIR 361 modulates ERG expression to regulate angiogenesis in metastatic cancers. Ms. Sidra Mumtaz, please.
Good afternoon, everyone. I'm Sidra Mumtaz, and I'm going to present microRNA 361 modulate ERG.
Ms. Sidra, would you share your screen, or do you want
Yes,
us to share for
I'm
you?
going to share. Please wait a while. I'm going to share.
Okay, please go ahead and share then.
Yes. Okay. Good afternoon, everyone. I am Sidra Mumtaz, and I am going to
Kindly put it in the presentation mode, please.
Yes. Okay.
Okay, please go ahead.
So I'm going to present the microRNA 361 modulate ERG expression to regulate angiogenesis in metastatic cancer. So angiogenesis is the formation of new blood vessels from the pre-existing vessel. So normally this process involves in the growth, development, reproductive cycle, wound healing, and granulation of the tissue during repair. It is very important hallmark of tumor growth in metastasis. Several types of the genes involved in the process of angiogenesis, such as VEGF-R1, VEGF-R2, VEGF, XAD4, EGFL7, and V adherent. And some of the genes are regulated by the transcription factor ERG. ERG is a member of X family of transcription factor. It is highly expressed in mature quiescent endothelial cells. Normally, this gene involved in the process of wound healing, vascular development, hematopoiesis, maintaining vascular homeostasis, and angiogenesis. And in some cancers, such as prostate cancer and leukemia, the expression of ERG gets upregulated. This gene also possesses the DNA binding and trans-activation ability of the target gene. There are several mechanisms, the regulation of ERG, mRNA in protein level that ultimately regulate the tumor angiogenesis. So one of the mechanisms is the regulation through the microRNA. So what is microRNA? MicroRNAs are the small non-coding molecules consist of 18 to 22 base pairs. They hybridize to the target genes either at 5-UTR, 3-UTR or coding region. And normally microRNA involved in the cellular processes such as cell cycle proliferation, differentiation, and apoptosis. They regulate the gene either by inhibition or direct degradation of the messenger RNA or the direct interference with the protein translation. So coming to our hypothesis, suppose this is the messenger RNA of ERG. If microRNA bind to the messenger RNA of ERG, it can interfere the ERG protein expression, which ultimately can halt the angiogenesis. So based on this hypothesis, our study objectives are to investigate the possible binding site of the microRNA on ERG messenger RNA, to analyze the effect of selected microRNA on ERG, and to target the angiogenesis via microRNA that regulate the ERG expression. So these are the methods that we use for our further downstream experiments, such as identification of the microRNA, cloning of the ERG, cloning of the microRNA 361, ectopic expression studies, ERG activity assay, effect of migration and proliferation, and analysis of angiogenesis target gene. So coming toward our results, these this figure show that the seed sequence that bind on the 3-UTR encoding region of the ERG. This figure show the number of binding sites of the microRNA on ERG, their target score, their minimum free energy, and location on the chromosome. So we did the cloning of the microRNA 361 in CGFP vector, and we cloned the microRNA 361 in as a fusion product of the ERG, fusion product of the EGFP. As we know, the EGFP is a green fluorescent protein, and then we check the green fluorescence after the transfection. So the expression of the microRNA 361 was analyzed by qPCR in prostate cancer and control samples. And the result in this figure show that the prostate cancer samples has a significantly low expression of the microRNA 361 in comparison to the control. After transfection of microRNA in the cubic cells, we check the expression of the microRNA in transfected cell in comparison to the control. And the result in this figure show that the expression of the microRNA 361 becomes significantly increased after the transfection in comparison to the control cell. Here we check either the ectopic expression of the microRNA 361 has any effect on the ERG expression at mRNA or protein level. So the result in this figure show that the expression of ERG becomes significantly reduced both at protein and mRNA level after transfection with the microRNA 361. So here we check if there is any effect of the microRNA 361 binding on the 3UTR or coding region of the ERG transcription activity. So the result in the figure A show that the binding of microRNA 361 reduce the ERG transcription activity in comparison to the control. Similarly, in figure C and D, the results show that after the binding of microRNA 361 on the coding region of the ERG significantly reduce the expression of ERG in comparison to the control in mutant transfected cell. So here we check the effect of a microRNA transfection on the migratory ability of the cells. So the result in the figure A show that the migratory ability of the group of cells that transfected with the microRNA 361 significantly reduced the migratory ability in comparison to the group of control cells. And figure B show the quantification of the migration assay, and which show that the microRNA 361 transfected cells has significantly reduced migratory ability in comparison to the untransfected control cells. After that, we check the expression of the downstream target, angiogenic target genes of the ERG after transfection of the microRNA. And here the results show that the downstream targets of the angiogenic targets of the ERG become significantly reduced as a result of reduced expression of the ERG after transfection of the microRNA 361. And similarly, we check the expression of the protein level angiogenic targets of the ERG, and results show that the B equivalent a downstream target of the angiogenic target of the ERG and becomes significantly reduced expression after the transfection of the microRNA 361. So the conclusion of this study show that the ERG3-UTR encoding region is a potential target of the microRNA 361. MicroRNA overexpression lead to the reduction in expression of ERG at mRNA and protein level. mRNA have the potential to downregulate the ERG and hence angiogenesis, and reduce angiogenesis can hurt the cancer metastasis. So this microRNA can be used as a potential drug target to regulate the angiogenesis in metastatic.
You have 1 more minute.
Okay, thank you.
Thank you, Ms. Sidra. And we have time for questions now, please.
Yes.
If there are any. Yes.
Thank you for a good presentation. How confident are you that your results could now be applied in vivo to actual patients?
Will you please repeat?
So based on your results, how confident are you that your results could be applied to actual patients and not just cell cultures?
First of all, after the cell culture study, we will move to, in our next project, we will move toward the mice modeling. After that, we will move, after getting the result from the mice model, we will, I will confidently move toward the patients also. Okay.
Yeah, I mean, so do you anticipate any difficulties in mouse models, because those are living systems as compared to cell cultures? You can't control all the conditions. So how confident are you for that?
Yes, we will design our hypothesis and things already. We are doing a small pilot study, and it is a bit difficult to do in mice model in comparison to the cell culture. The conditions are naturally not controlled in the cell mice model in comparison to the cell culture. So we already started our pilot project, and also it will be good.
Are there other questions?
Thank you for that. That was a very nice presentation. If you find that
disrupting angiogenesis with this microRNA affects normal tissue in an adverse way. Have you thought about ways that you might deliver this microRNA to tumors selectively in vivo?
Yes, it could be, but first of all, we will induce tumor in mice, and we will induce it in vivo in mice. Then after that, we will move toward the tumors later. Later, after doing study in the mice, first of all, in mice we will induce a tumor, and after studying their effect of this microRNA at mice level, then next we will go toward the selected tumor approach.
Okay, thank you, Ms. Sidra, for a very nice presentation. And we'll move on to our next presenter, which is Dr. Misbah Yunus from Aga Khan University Hospital in Karachi, Pakistan. And she will be talking about pathological outcomes in stage 2-3 rectal adenocarcinoma patients undergoing neoadjuvant therapy versus total neoadjuvant therapy at a tertiary care hospital in Pakistan. Dr. Misbah.
Good afternoon, everyone. My name is Dr. Misbah Yunus, and I'm currently working at Aga Khan University Hospital as a medical oncology resident. So I'm honored to present my research here on pathological complete responses in patients with stage 2 to 3 rectal cancers treated with neoadjuvant protocol at a tertiary care hospital in Pakistan. That's not going. Okay. I have no conflicts of interest. So this is the latest data on, this is a National Cancer Registry data from 2015 to 2019. And this was recently published in JCPSP in June 2023. And it shows us that colorectal cancers are the third most common cancers in Pakistan. In females, in overall, they are 4.78%. In males, it's 6.43%. And in females, it's 3.36%. So we have come a long way in treatment of rectal cancers, starting from 1985, where only upfront resection was done. And then we saw a benefit of adjuvant chemoradiation. Then we moved on to post-operative chemoradiations, to pre-operative chemoradiations. Then came in the role of short course versus long course chemoradiation. And now we are in 2020, we had approved 2 of the trials, Rapido trial and PRODIGE 23, giving us PCR benefit in total neoadjuvant therapy. And now we are even moving forward with OPRA trial coming in, and we now have waitful watch approach. So we designed a retrospective cohort to see that how our patients in real world were treated on total neoadjuvant and neoadjuvant approaches. So we took patients from stage 2 to 3 rectal cancers. These were diagnosed from 2017 till 2022, and they were treated on neoadjuvant chemoradiation and surgery approach. So the patients were stratified according to NT and TNT group, and primary endpoint was overall response rates, in which we saw PCR, near complete response, partial response, or no response. We also had a look at drug and related side effects. So we included all patients between 18 to 70 years. We only took patients who were diagnosed at rectal carcinoma in stage 2 and 3, and they were planned to receive all their treatment at our primary institute, including surgery, chemoradiation, and those who underwent surgical resection with APR and LAR procedures. We excluded patients who develop metastatic disease even during the period of neoadjuvant therapy. All patients with upfront resection were also excluded. So after extensive review of all the records, we had 77 patients, out of which 60 patients were in the neoadjuvant group and 17 patients were in the total neoadjuvant group. So overall response rates now in the TNT group, although we had 17 patients, and that's because TNT approach came in 2020 and we started clinically applying it in our practice somewhere around 2021. So we had 17 patients. Out of them, 76% had overall responses, which included PCR, NCR, and partial response. And in NT group, 62% of the patient had overall responses. So these were 52 patients in total who had response out of 77 patients, and the p-value was statistically significant. Now coming on to the specific responses in each group. So you see this graph in this, 27% of the patients, including TNT and NT group, they had complete response or pathological complete response, that there was no viable tumor cells in the pathological specimen, followed by NCR 25% and 14.2% had a partial response. Now, whenever we see rectal carcinoma trials, especially in NT or TNT, both approaches, PCR rates differ somewhere from 17 to 20% to 30%. So this was kind of representative of what we have been seeing in trials. So this is a histopathological representation of rectal cancer forming glands and exhibiting nuclear atypia. And after neoadjuvant chemotherapy, you can see that the tumor bed only has fibrosis and inflammation. And this is the kind of responses that you see in patients when we treat them on either neoadjuvant or total neoadjuvant approach. So our patient, coming on to our patient characteristics, most of my patients were in clinical stage 3, 83% in the NT group and 100% of them in the TNT group. CRM was positive in 6 patients in standard group, and TNT had 1 patient. Negative in 43 patients, 71%, and versus 82.4%. Most of our patients had received K-pox rather than FOLFOX. APR and LAR both were done in both the patients. So out of these patients, around 9 patients had received short course chemoradiation. And mostly in standard group, they had 60 patients had long course chemoradiation, which is the standard of care. Both are standard of care, but short course was only 9 patients because we had started in somewhere around mid of 2021. So the high risk features, mostly our patients were in clinical stage T3 and 1. LVI was present in 13% of the patient versus 29.4%, and PNI was present in 26% versus 35.2%. So we also had a look at the adverse events, and neuropathy was seen as the most common adverse event in NT group and TNT group. And 25% of the patients in NT group had neuropathy. So this was one of the most common side effects that we came to know. So since most of these patients were taken from 2017 to 22, median overall survival has not reached yet. So on that note, I would like to end my presentation. Thank you everyone for this opportunity to present.
We're open for questions, please.
Okay, it's more, oh, okay, sorry, yes.
Can you hear me? So as in breast cancer, we can see that there's so many trials who were looking for the pathological complete response.
Yes.
And there was no survival benefit in that. So do you think going for the TNT or NT would have any benefit for the survival difference? So is there would be, because all the trial didn't show any benefit, any difference in the survival of these trial. So how confident you are from your ongoing ongoing
So,
that there will be
formally, I was not comparing TNT and NT approach in my retrospective cohort. I was just looking at the outcomes that our patients had in these on these treatment approaches. PCR also, you know that it is one of the one of the baseline parameters that's always evaluated whenever we are looking at any kind of neoadjuvant approach. So that's what I
But
would
is
like to
it
say.
is it going to affect the survival?
It is going to, because if there is PCR, it is going to affect overall survival. It is one of a surrogate marker of overall survival.
But in the breast, it didn't show any difference in the patient who achieved the PCR and those who didn't achieve. How confident you are that there will be the difference in the?
I think these trials were, when PCR was reported in Rapido and ProRage, they were in 2020, and I think we have to wait for extended results to see if they translated into overall survival as compared with breast cancer.
Thank you.
Okay, a related question. The sample size is unequal and one is so small that you cannot compare the results, even though you got percentages with the other.
Yes.
So to me, from this particular study, you should not draw a conclusion. As to
True,
which is
I
better.
agree with that. Sir, because, you know, this was a retrospective analysis of what we have been doing at our institute. This was not a comparison between NT and TNT. It was just that this NT was introduced somewhere in 2020 and we started applying it in 2021. So this was just an analysis of what we have been doing in our institute. To, of course, to have a complete comparison between these two treatment groups, we would have to enroll a lot more patients. Yeah. Thank you.
Thank you, Dr. Sumro. That was a very informative presentation. Okay, so the next one is by Mr. Ali Islam from Shaukat Khanum Memorial Cancer Hospital and Research Center in Lahore. And Mr. Islam is going to talk about next generation sequencing, unraveling genomic variants relevant to clinical practice.
Thank you, Dr. Asif. Assalamu alaikum and good afternoon, ladies and gentlemen. I'm Ali Islam from the Molecular Pathology of Shaukat Khanum Memorial Cancer Hospital, and I'm privileged to present the first ever NGS oncology data from Pakistan using 50 gene cancer hotspot panel. So I'll be presenting the marvels of next generation sequencing, unraveling genetic variants of clinical significance. So NGS is a tool for sequencing DNA and RNA that is a high throughput sequencing technology, meaning thereby that it can interrogate many genes simultaneously, so that resolving the tumor specific genomic profile that may include SNVs, copy number variations, insertions, deletions, chromosomal translocation, and so on. So that is translated into the personalized or precision medicine. The World Economic Forum has recognized the precision oncology is the best new weapon to defeat cancer. So based upon this NGS data, the FDA has given the accelerated approval to the NGS-based assays for actionable genomic aberrations to be identified. And finally, this slide is just to show you the vast applications of NGS, not only in clinical oncology, but in high resolution transplant screening, clinical genomics, rare disease, personalized medicine, and so on. So let me briefly take you through the very complex workflow of next generation sequencing, in which a sample is first histopathologically reviewed to mark the tumor content, followed by nucleic acid extraction, and the library preparation, in which each DNA fragment is given a unique identifier and subsequently to be normalized and pooled. And finally, the sample is sequenced, and the data from each sample is bioinformatically analyzed, and undoubtedly the most tedious job ever. So these are few of the databases Out of them, there are a few of them that are FDA approved that include Clinvar and OncoKB by Sol and Catering to infer the genomic variants of clinically actionable targets, specifically include clinically actionable variants. Based upon them, there are companion therapies and clinical trials available, and drug response association that includes the marker for drug sensitivity and drug resistance, and most importantly, the functional evidence of pathogenicity. So based upon the NGS data that we have performed in our lab, I'm going to present 3 of the cases. That here we have the case 1, where a 52-year-old female was presented with right breast lump, and histopathology report has shown that it was invasive ductal carcinoma grade 2. So IHC markers were performed that have shown ER/PR to be completely negative, and HER2 plus was equivocal. So the reflex testing was ordered, and the sample came to molecular lab, where we have performed FISH HER2/neu that was shown to be negative and has clearly depicted the case of triple negative breast cancer. As the mother of patient has died of breast cancer, so the BRCA1/2 genomic screening was ordered that was performed on RT-PCR that has shown to be negative. So I may add here that we are going to shift the BRCA1/2 genetic screening to NGS very soon in our lab at Shaukat Khanum Cancer Hospital. So when the same sample was performed on NGS, look, amazingly, it has shown the very astonishing results that has shown the PIK3CA pathogenic mutations. So it has become very important to screen the PIK3CA genetic mutations that almost 40% of breast, ovarian, and cervical cancers are found to be associated with them, and that there has been an approved therapy for them, that is alpelisib. That's why this is very important to screen the pathogenic variants in breast cancer especially. So later to that, we have a case 2, where a 47-year-old male was presented with lung mass, and clinically it was metastatic adenocarcinoma of lungs, and molecular tests were separately ordered for the single-plex KRAS and EGFR-based assays that have shown no identified mutation. But when the same sample was performed on NGS, that has shown very surprising results. That was the SMAD4 pathogenic deletions, and that was a poor prognosis, in addition to a PTAN mutation that was likely pathogenic. So in the note, we have that the SMAD4 deletions are the poor prognosis, as they spontaneously promote the independent tumor formation and accelerate metastasis. And sadly, we do not have any companion diagnostic for SMAD4 yet. So there's a case 3, where a 25-year-old male was presented with brain tumor, and the clinical indication was oligodendroglioma. And the molecular tests were ordered that include 1p19q FISH positive and IDH1. So it was IDH1 mutant glioma of grade 2. So when the NGS was performed on the same specimen, so we found the very interesting results. Look, in addition to IDH1, we have also found the KRAS pathogenic variant, that is the very classical mutation of G12. And in addition, we have a TP53 pathogenic variant. So that clearly depicts that the single-plex assays are not that much comprehensive to screen the complete genomic profile. So in the note, we have the KRAS mutated gliomas are associated with shortened survival, and there is an increasing evidence of KRAS mutations in gliomas that are to be accordingly treated. So this is the 50-gene cancer hotspot panel that we are using in our lab that has 2,800 cosmic mutations built in there. And this is how we report the NGS molecular biology data. So I think the given cases would help to investigate and interpret these data analysis reports. And finally, the variants are accordingly tiered and reported according to their evidence of pathogenicity into the 4 different tiers. So this is the NGS data that we have performed in our lab that is accordingly distributed into the breast, ovarian, endometrial, lung, and colorectal carcinoma and others, with the relative distribution of breast and ovarian carcinoma being the highest, constituting the 29% of the total cases, and lung cancer being the second highest one, and GIT and CRC cancer were the least by 20%, and the other carcinomas that include signet ring cell carcinoma, squamous cell carcinoma, spindle cell carcinoma, sarcoma, and melanoma, and TCC bladder were found to be 25% of this cohort. So this may be very important to you. So as explaining the whole landscape of the mutations that we have identified in our samples. So that is the mutation in KRAS classical exons, specifically codon 12 and 59, and the second highest being the PIK3CA, SMAD4, EGFR, and BRAF. In addition to that, we have another class of mutation that is TP53. So screening the TP53 give us a valuable information as any mutation in TP53 would have the consequences leading to the cancer. So in the summary, NGS is a robust and powerful tool for interrogating different disease-causing genetic variation and mass. So NGS has transformed the era of single gene diagnostics to multi-gene panel testing, because the single gene-based assays are not enough to screen the genome-specific or the tissue-specific genome profile to be accordingly treated. And NGS may seem costly, but it enhances the chances of therapeutic success and offers the cost-effective precision or personalized medicine that is the right drug at the right dose to the right patient at the right time. And it goes without saying that the Shaukat Khanum Memorial Cancer Hospital is the only organization in the Pakistan doing 50 gene panel on the NGS. Last but not least, we're going to further expand this panel into a 70 gene panel, where you'll also get the ALK and EGFR fusions, including CNVs and RNA fusion partners, anti-RK fusions, and MAT14 exon skipping. So you want me to order them separately. So in the end, I would be grateful to my section head, Dr. Romina Kazi, for her constant support, and thankful to the chair and the senior management of the hospital for their tireless efforts to bring the cutting edge technologies and for improved diagnostic and better patient management. And with all that, thank you very much.
Okay, we have time for 2 minutes for questions. So any questions here?
Okay. Ali, thank you for bringing up a topic which is really something which has to be done in Pakistan, and I'm glad that you started that. We started a little bit of that in RMI, and so we are familiar with it. But I'm glad that you've got results, and I would like that you follow up on that, because what we found was based on the Illumina catalog or the panels, our results, our genes are slightly different from what they have said. Because that panel is based on a Western population, our genes are probably different.
Yes.
So I'm glad that you've got results, but to look really at diagnostic, prognostic, and therapeutic aspects, you have to first have a database of normal people, and then the patients, and then do the comparative studies, and then bring it out. But excellent effort. Yeah.
Okay, so my understanding is that this is sampling of tumor DNA and
Yes.
not
Yes, sir.
person DNA. So when you sample DNA from a person, one of the features that can come up is clonality, and clonality is obviously one of the features of tumor evolution. So as a non-tumor expert, I work in intensive care. Just out of interest, how do you deal with clonality? How do you know that if a mutation is present in only, for example, 1% of the cells,
Yes, sir.
that is important for that tumor as a bulk?
Yes, sir. So whenever we screen the NGS data, so we use different various bioinformatic pipelines. Based upon that, we have the variant allele frequency that clearly depicts the relative percentage of the mutation in the tumor specimen. So once the specimen is histopathologically reviewed, it shows if there is a 40% tumor content. And if we are getting the 100% of the same mutation in that 40% tumor, so that means that tumor has no clonality in that. So when there is a variation in the relative allelic frequency of a same variant, then we came to know that there is a tumor heterogeneity. And based upon tumor heterogeneity, we identify the drug response association marker and the resistant markers. So the VAF, the relative allelic frequency, is the answer to the tumor heterogeneity. Thank you.
Thank you, Ali, for an excellent presentation. Okay, we will move on to our next talk, and that is by Dr. Abdullah Altaf from King Edward Medical University in Lahore, Pakistan. And Dr. Abdullah would be talking about impact of an artificial intelligence-based model to determine transplant eligibility for hepatocellular carcinoma. Is this virtual, Anika? Is this virtual?
No.
He's not here. Is Dr. Abdullah here? Is it? It's virtual, so can you please check? Okay, so unfortunately, Dr. Abdullah Altaf is not here, so we'll move on to our next talk, and that is by Dr. Mahnoor Asim from Shaukat Khanum Memorial Cancer Hospital and Research Center in Peshawar, Pakistan. Dr. Mahnoor would talk about time to change prevalent culture, day of surgery admission in elective oncological surgery at SKMCH Peshawar. Dr. Mahnoor.
Good afternoon, ladies and gentlemen. It's a pleasure to have you all here for this wonderful session today. I am Dr. Mahnoor Asim, currently working as medical officer in surgical oncology at Shaukat Khanum Hospital, Peshawar. Today, I'm going to discuss about bringing a change in our prevalent surgical culture. That is day of surgery admission in elective oncological surgeries at Shaukat Khanum Memorial Cancer Hospital, Peshawar. For those of you who are not familiar with the term DOSA, DOSA basically means admitting the patient on the day of surgery. Can I just interrupt? This is not the same presentation that I had. I did not have this presentation. It was the other one I will give him right away. Would you have shared this one? No, it was the other one actually. जो मैंने USB में दी थी. जी मैंने इनको अभी दिया नहीं वो दूसरी.
Okay, we'll just hold on the time, please. USB.
Yeah, I do have it, and I did share it earlier too.
Can you hold the time, please? It's okay, we start, don't worry.
Yeah, ma'am.
Just to make things clear, since there was a problem with the uploading of presentation, we're going to restart and give her full 8 minutes.
Okay. As I already introduced myself, so let us continue with the remaining section. So what is DOSA? DOSA basically is admitting the patient on the day of surgery.
Little bit close.
Okay, why DOSA is the need of this hour? We need to implement DOSA in order to appropriately utilize our resources and the limited amount of beds available at the hospital. On the other hand, enhanced recovery after surgery is also a known component of DOSA. At Shaukat Khanum Memorial Cancer Hospital, Peshawar, we have an increasing load of patients. In order to cope up with that increasing load of patients and to utilize our resources appropriately, we need a new health approach, and that is DOSA, which will grant equal access of health to all the patients. There's lack of research in Pakistan regarding DOSA approach. Well, in the Western society, if we see it's well established. From a study published in Oxford in January 2021, it showed that 97.8% lung resections were carried out via DOSA approach. And surprisingly, patient satisfaction rate in that case was even reported as 100%. The components of DOSA. DOSA basically includes first is to review the patient in surgical OPD, followed by identification of patient. Once the patient is identified as candidate for DOSA, after that, we carry out extensive anesthetic evaluation. After extensive evaluation comes the important component of DOSA. That here is education and optimization. After education and optimization, we have another important component known as patient communication. In the end, once the patient arrives on the day of surgery, we keep them in holding bay, and after surgery, we shift them to the ward. The objectives of our study were basically to implement DOSA at Shaukat Khanum, Peshawar, and secondly, to evaluate the safety, sustainability, efficacy, and cost effectiveness. And finally, to analyze the outcomes. It was a three-phase retrospective study conducted from January 2021 to October 2023. And in this study, we included patients who underwent elective oncological surgeries and excluded those who underwent emergency procedures. The data was analyzed using SPSS. This is the timeline for DOSA approach, starting from the pilot study conducted by our hepatobiliary colleagues, and then our colorectal colleagues joined it, and finally our upper GI even became a part of this project. So our DOSA pathway basically started with a pilot study conducted in April 20 to March 21. We chose cholecystectomy as a surgical procedure for the sake it had low risk factor. And the total of 14 patients underwent DOSA approach, which can be visible from the pie chart. Then we said, why not apply this DOSA for the major surgical procedures? And we carried out our pre-DOSA phase. And in the pre-DOSA phase, we just carried out one major surgical procedure. And luckily, it had no difference in outcomes as compared to those admitted preoperatively and those who underwent DOSA approach. Then in the phase 1 of the study, we conducted DOSA to majority of the surgical procedures, which were major surgical procedures. And in 2021, we saw 54.3% prevalence, which further increased to 67%. So as our colorectal fellows saw that the DOSA in hepatobiliary setup was successful, they decided, why not let us give it a try to it? And they applied DOSA first time to their minor surgical procedures, such as reversal of stoma, with a prevalence of 73%. Then later, they carried out a pilot study dividing into two teams, Team A and Team B. The difference between two teams was Team A was for major surgeries undergoing DOSA approach, and they had more cases, as compared to Team B was for minor surgeries. And luckily, there was no significant difference in the outcomes for both the teams. In the phase 2 of the study, we saw a huge, wonderful prevalence in DOSA approach, and that was from April 2023 to October 2023, and it was a hard work of our both hepatobiliary and colorectal colleagues with a total prevalence of 88.5%. Then in the phase 3 of the study, we had our upper GI colleagues joining us with a total prevalence of 62.5%. These were the major surgical procedures carried out by hepatobiliary team in the form of pancreatic resections, liver resections, and radical cholecystectomies. Whereas colorectal team carried out laparoscopic colectomies and anterior resection. On the other hand, upper GI colleagues carried out esophagectomies and gastrectomies. These are the numbers shown, the exact figures how we carried out these procedures. Comparing the outcomes pre and post DOSA implementation, we could see no significant difference as the p-value was more than 0.05. As surgeons, we all were satisfied with DOSA approach, but we wanted to know whether our patients were satisfied or not. For that, we conducted a survey starting from May 2022 to May 2023, and it's still an ongoing study, and we found 100% satisfaction rate. Not only it was satisfactory from the patient side, we also saw the cost effectiveness of 40 lakhs since the DOSA started at our setup. In conclusion, I must say that DOSA is safe, implementable, cost-effective, high satisfaction among patients, and sustainable. Although it was a successful project in our setup, we though faced some limitations initially that were cultural beliefs of patients and reluctance to change the prevalent practice among the surgeons. In future, we would like to see surgeons to adapt DOSA as their common practice. These are the references. Thank you very much for your patience and letting me have this opportunity. Thank you so much.
Thank you. We have some time for questions, actually. More than 2 minutes, but welcome any questions.
See, I wonder why the clinical people are not asking questions, so I have to back up for that. Very good attempt. I just want to say that, if you want to change practice, you have to do basically RCTs or to generate evidence-based data for changing practices. Because short of that, nobody would change the practice, no matter how good the results are. So I would urge you, this would be like a pilot study because one, it's retrospective, and second, you have not done it in terms of an RCT. So I would request that you in future develop a trial and then see what the results are according to the rules of proper RCTs. And then we could think of changing practice. Okay.
All right. Okay.
I just have one question, which was at the beginning of your talk, you mentioned about the flow and it involved patient education.
Yes.
And I just wondered if you could elaborate a bit more on that. So from the patient's perspective, what's changed for them? What have you had to educate them about?
Sir, thank you for the question. We basically educate the patient. Sorry, I'm sorry. Okay, thank you for the question. We basically educate the patient on the basis of enhanced recovery after surgery guidelines. First is counseling. In counseling, we counsel the patient about advantages and disadvantages of the surgery and how to prepare themselves for surgery. Once that's done, for example, if I might give an example of our colorectal fellows, they basically educate their patients specifically about stoma. That is how to manage it and whether it's ileostomy, so it might get dehydrated and they might need more fluids. So stuff like this is addressed. And secondly, they're told when to come on the day of surgery and how to prepare themselves, like how to be NBM. Thank you so much. Thank you.
Oh, there's one more question, please. Yeah.
Just a little question. Did you notice any difference in cancellations on the day of surgery with the DOSA approach?
Sorry, I did not follow your question.
Did you notice any difference in the rates of cancellation of surgery on the day of surgery?
So it has a difference in a sense that it is appropriate utilization of resources and it helps us to deliver equal health to all patients. And secondly, we try to implement ERAS guidelines, which is making patients responsible.
No, so that's not the question. The question was, as a consequence of implementing DOSA, were some patients cancelled on the day of surgery?
Okay.
Did that happen or not?
Sir, there's a difference. Like we do, if we implement DOSA on patients,
okay, don't worry. Thank you very much.
Cancellation. Oh, sir, so far we haven't had any cancellations because we in OPD review them in detail and we order their tests. And even on the day of surgery, when they come, if something is deranged, we reorder it again. And then by the time patient is under anesthesia, we know all the results and everything is ready. I'm sorry for not understanding. Thank you so much.
Okay, thank you, Dr. Manur. So we're now up to our last presentation, and that is by Dr. Muhammad Hasnain Chatta from Shaukat Khanum Memorial Cancer Hospital and Research Center in Lahore. And Dr. Hasnain Chatta is going to talk about comparison of propofol total intravenous anesthesia versus inhalational sevoflurane on the quality of recovery in cancer patients undergoing day case cystoscopies. Dr. Chatta, please.
Good afternoon, everyone. My name is Hasnain and I work in the anesthesia department at Shaukat Khanum Hospital. The work that I'm presenting today is a comparison of two anesthetic techniques, total propofol anesthesia versus traditional inhalational sevoflurane. There's no conflict. Okay, this is not good thing. So this is not good thing. So there's no conflict of interest. Throughout the world, with advances in healthcare, there is a decrease in the morbidity and mortality of cancer patients. But Pakistan has increasing number of new cases along with a high mortality rate. The challenge to deal with these new cases and the struggle to preserve the quality of life in cancer patients has become a burden on our healthcare system. We use a multimodal approach for the treatment of cancer, but surgery remains the cornerstone of cancer care. It is used to remove early tumors, staging the disease, and look for any recurrence. Shaukat Khanum Hospital is the largest comprehensive cancer care center in Southeast Asia. We had almost 10,000 surgical procedures done in 2022. 1,389 out of these were urological procedures for the surveillance and treatment of bladder cancer. This is a major chunk of procedures being done at our hospital, almost coming out to be 14%. So when I joined Shaukat Khanum, we had the anesthesia was conducted using the traditional inhalational sevoflurane. Among the several disadvantages of using this technique, delayed recovery and a 10% or more risk of emergence delirium, especially in the elderly population, was a major concern for us. Alternatives were being looked into, with propofol coming out as a promising candidate, but it was deemed to be more costly than the alternatives. It was at this time that data from in vitro and animal studies proved to be a game changer for us. The evidence, ladies and gentlemen, a higher rate of recurrence with sevoflurane. It was the evidence like the one shown here on screen, which prompted us to look into the possibility of comparing the shortfalls and the benefits of one technique over the other. Hence, we designed a single-blinded randomized controlled trial to look at the quality of recovery in post-operative patients undergoing urological procedures. Our aim was to look at these patients on post-operative day 1. We used a verified assessment tool, the QOR40, which looks at the quality of recovery in post-operative patients using a set of 40 standardized questions. A brief summary is illustrated here on the screen. This tool has a minimum score of 40 and a maximum score of 200. Higher the score, better the recovery profile. We included patients from both the genders having an age above 18 and those with ASA grade 1 and 2. Patients having any history of drug allergy were excluded, along with any inpatient admissions which weren't planned. So in total, we randomized 88 patients into 2 groups. One group received IV propofol through the duration of anesthesia, and the second group received traditional inhalational sevoflurane as a control. The study protocol was standardized, where everything was strictly kept uniform between the 2 groups, except for the choice of maintenance anesthesia. The demographics came out to be uniformly distributed between the 2 groups. We used SPSS software for analysis. How little do doctors understand the health through which we put patients? This is why my results are important. Ladies and gentlemen, I need your attention here. So the global mean recovery score for the propofol group came out to be much higher than the sevoflurane, and this difference was found to be statistically significant. Further, we went on to analyze the 5 components of the QR40, namely physical comfort, emotional state, physical independence, psychological support, and pain. Again, we found that the propofol group fared consistently better in all 5 subsets of QR40 as compared to the sevoflurane. We found that the 4 out of these 5 subsets were statistically significant as compared to the sevoflurane. When the patient suffers, the whole family suffers. A higher score in our questionnaire means that we have a better patient satisfaction. It is actually this satisfaction which gets translated into a domino effect for the whole family, and thus our results. This slide will require your special attention. One of the deterring factors for propofol has been its higher cost. But we found that for short day case surgeries, it might actually be cheaper to use propofol as compared to the sevoflurane. For the cost for 88 patients came out to be 238,000 in the propofol group as compared to 260,000 for the sevoflurane. Extrapolating this data, we found that in year of 2022, we would have saved almost 350,000 rupees just for cystoscopies. Our estimate is that this figure will go exponentially higher if we use propofol for all day case surgeries in all specialties. The strength for my study that this was a randomized controlled trial and we used a well-established tool for the assessment. As with every study, we had some limitations, one of them being that this was a single blinded study and we used estimation method for the cost calculations. So what does our study prove? Our study proves that the quality of recovery improves significantly when using propofol for the conduct of anesthesia. And what about the cost? It further predicts that it would be more cost-friendly for the hospital if we use propofol. As we reflect back on our study, it becomes evident that the mind and the emotional state of the patient has a profound effect on post-operative recovery. In words of John Milton, the mind is its own place and in itself can make heaven of hell and hell of heaven. Thank you.
Thank you, Dr. Chatta. And we have some questions, time for questions, 2 minutes actually. Sure.
Thank you very much, Ahsan, for such a nice presentation. I have just one question. Cystoscopy, as we all know, is a very short procedure. So, can you tell me, आपने propofol जो है वो कैसे use किया था? Infusion pump में किया था या with small boluses?
We use the technique of IV boluses for the total intravenous propofol.
Okay, thank you very much.
Welcome.
Okay, thanks for that nice presentation. You measured the recovery of the patients on the first post-operative day or at the time. How long do you think, or did you measure it? How long was that difference in recovery maintained for? So, I mean, for example, you were saying that this affects the patient. If it affects the patient, it affects the family. There's no doubt about that. But was this just a difference that only lasted for 1 or 2 hours? Or did you yourselves notice that this lasted longer?
So the questionnaire itself is a comprehensive questionnaire, which when it asks the question, it asks for the last 24 hours of the quality of recovery. So it would ask questions, how did you feel right after your surgery? And how did you feel when you went home? Were you able to perform your daily activities when you were home? So this is, it covers the 24 hours. And after 24 hours, we ask the questions.
That pain was not statistically significant on post-operative day 1. Do you think this approach could be adopted for the longer procedures?
Because the pain was not significant would mean that we might need a higher number of patients to actually determine if this might be something which would be significant in more patients. But to answer your question, if this is for the longer procedures, the pharmacokinetics would actually be more pronounced and the results could be even better than these ones. Thank you.
Yeah, I have one question. One, I don't know, I'm not a clinician, but do you have different types of cystoscopies for different types of conditions? And did you test for those, or is it just one standard procedure, maybe just looking at the inside of the bladder? And second, was the duration of giving anesthesia the same, because cystoscopy procedures would be different? So were those standardized between the two, randomized groups or not?
So this is a good question. We just used the small procedures, which were mostly check cystoscopies, but in the retrospect, we did check the both the groups from the sign-in time that our patient goes into the operation theater and the sign-out time, the time when it comes out. And the difference between the two times were not significant. So we were able to say that both the groups were comparable. So that was in the retrospect that that was a question that came up in our mind, and we compared the two.
So we have one last question by Dr.
So I'll make it very quick. You said you were using this for check cystoscopies. Now, correct me if I'm wrong, but most check cystoscopies is done under local anesthesia with lignocaine jelly. So why were you giving intravenous propofol for this?
So there, I think the surgery people would be more able to answer this, but there are two procedures. One is the BCT, I think, which normally goes in the one of the other theaters, not the general anesthesia theaters. But we have a list where we get almost 15 to 25 check cystoscopies which undergo general anesthesia every day. So this was one of the reasons we chose this. All right, thank you. Thank you.
Okay, thank you, Dr. Chatta, for a very nice presentation. We now have Dr. Abdullah Altaf from King Edward Medical University, Lahore, to talk about impact of an artificial intelligence-based model to determine transplant eligibility for hepatocellular carcinoma. He's joining us online.
Thank you so much. Assalamu alaikum, everyone. So let me just quickly share my screen. I hope everyone sees my screen. So first of all, I'm really excited to be here at the Shaukat Khanum Cancer Symposium, and I'm really excited to share a research study which we did at Shifa International Hospital. So the title of our research study is Impact of an Artificial Intelligence-Based Model to Determine Transplant Eligibility for Hepatocellular Carcinoma. So to begin, I would like to mention there's no any disclosure per se. So first, I would like to begin with a bit of background to our study. So for carefully selected patients with hepatocellular carcinoma, liver transplantation is a viable treatment option. Careful selection of HCC patients for liver transplantation is therefore the key. And while the Milan criteria, the gold standard liver transplant criteria, a number of liver transplant criteria have been proposed over the year that include the UCSF, Kyoto, up to 7, etc. And they have been proposed over the years to increase transplant eligibility while making sure that the oncological or overall survival outcomes are not compromised. So the emergence of artificial intelligence healthcare has been no less than groundbreaking. And deep learning, which is a newer cutting-edge branch of AI, uses an algorithmic architecture layered like the neural networks of our brain to analyze data. Now, this might sound very complex, but basically what it means is that deep learning works exactly like the human brain. And as we can see in the figure on the top right, that just like a neuron receives information from multiple neurons and then processes that information and then passes that information downstream to make any decision. In the same way, a deep learning, in the part D of the figure, we can see that a deep learning neural network consists of multiple nodes, and each node receives data from nodes that lie upstream to it. It processes that information and picks patterns or algorithms in that information and passes it downstream. And when it is input information, it is able to make prediction using those patterns it has picked. So the application of AI to select HCC patients for liver transplantation has only been reported recently, and it has shown promising results. So the primary objective of our study was to develop a deep learning model for the prediction of 5-year post-liver transplant recurrence of hepatocellular carcinoma, and the secondary objective was to compute the weightages of different parameters in predicting recurrence of HCC after liver transplantation. And what we hypothesized was that a dynamic deep learning model can be used to accurately determine liver transplant eligibility for HCC patients on the basis of their 5-year predicted risk of recurrence. So coming to the methodology of our study, this was a retrospective cohort study done at the Department of Liver Transplantation, Shifa International Hospital, Islamabad, from May 2012 to August 2019. We had 192 patients in our study, who were randomized into the training and validation cohorts with the split ratio being 80 to 20%. 2 prediction models were developed. The first model used 8 pre-transplant factors that were age, gender, maximum tumor size of CT, tumor number of CT, number of lobes involved, AFP levels, neutrophil to lymphocyte ratio and response to taste, which was categorized either as good or bad response. And in the second model, we integrated histological grade into apart from these 8 pre-transplant factors. To test the prediction power of the AI model, ROC curves were plotted and area under ROC curves was calculated, and Kaplan-Meier survival analysis was done to assess and compare recurrence-free survival and overall survival. And the SHAP or Shapley additive explanations algorithm was employed to compute factor weightages. Coming to the results now, so the mean age of the patient was 52.8 years, median tumor size was 2.7 centimeters, median tumor number was 1, median AFP levels were 15.2 nanogram per milliliters, median NLR was 2.6, 35.4% of the patients were outside Milan criteria and 27.6% were outside the UCSF criteria. Patients who had either grade 2 or grade 3 tumors were 89.6%, and median follow-up duration was 59.1 months. So coming to the ROC curves, so first of all, like I said, we built 2 models. One was AI model without grade, and the second model integrated integrated histological grade. So as we can see that on the figure, in the figure on the left is that for the AI model without grade, the area under curve for the training cohort was 0.864, and for the validation cohort was 0.717. So if we compare with the AUC for Milan and UCSF criteria for predicting post-liver transplant recurrence, it was higher, because for Milan and UCSF criteria, we found out that it was 0.646 and 0.598 respectively. And when grade was integrated into the AI model, the AUC improved to 0.875 in the training cohort and 0.771 in the validation cohort. So coming to the Kaplan-Meier analysis now. So based on the AI model predictions, patients were classified either as low risk or high risk. And as we can see in the figure on the left, that the 5-year recurrence-free survival in the low risk group was 92.6%, and in the high risk group it was 45% respectively, and on log rank test the p-value was 0.009. So this was AI model without grade, and when grade was integrated, the 5-year recurrence-free survival in the low risk group was as high as 96%, and in the high risk group was as low as 30%, and the p-value on the log rank test was less than 0.0001. Coming to the factor weightages, in the AI model without grade, tumor size, AFP, and response to taste were the 3 most significant factors as shown by their high mean SHAP values. And when grade was integrated, tumor size, tumor grade, and AFP levels were the 3 most significant factors as shown by their high mean SHAP values. So based on our results, we came to the conclusion that the AI-based model might improve the determination of transplant eligibility for patients with hepatocellular carcinoma. And not just as a tool to select patients for liver transplantation, but it can also be used to inform patients about the accurate disease prognosis post-liver transplantation, devise individualized post-liver transplant surveillance strategies, and identify patients who can benefit from adjuvant therapies post-liver transplantation. These are all the references, and thank you so much.
Thank you, Dr. Abdullah. We have time for a couple of questions, please.
Sure, thank you.
Thank you for that presentation. I'm just wondering, the size of the cohort was not massive, and I just wonder, what do you think about the possibility that the model is overfitted to the data? So in other words, the data is so narrow that this model it has developed through the AI overfits. So for example, you take it to another population, it would behave differently.
Thank you. So basically that was our biggest limitation of our study, that we had a very small patient data set. So for patients from the mentioned dates, we had only 243 patients who went liver transplantation for HCC at Shifa International Hospital. And out of those, around 40-ish patients had extra hepatic metastasis, or sorry, not extrahepatic metastasis, they had portal vein invasion. So we excluded those patients. So that's why we were left with only 192 patients. So, and to address overfitting, what we did was there's thing called regularization. So we added that added regularization into our code to address overfitting, and based I couldn't show curves from our learning, like the learning curves from our model, but what we achieved and what we got in those learning curves was that there was not significant overfitting in our model. So yeah.
And one more question from me, which is that one of the strong points about AI, or at least it's a perceived strong point of AI, is that it's supposed to be unbiased. But I believe one potential source of bias here, which is actually very fundamental to the study, is the variables you chose to feed the model. What do you say about that?
So basically, what we did was that we selected these variables on the basis of like their significance in the already reported literature, and also one very important thing was the availability of the data. So so we chose these 8 variables based on the literature review and on the availability of the data. Yeah. And that is one of the limitations.
Yeah, thank you for a new presentation in terms of new work done. However, I'm puzzled a little bit. If you fed in data, which are standard, protocols for prediction, Milan and others, and your AI is based on that, you should expect similar results. How do you get the difference of better results? From where does that come in? I mean, if the Milan says 100%, then that should say 100 or something less than that. How does it become 101 or 102? 2 plus 2 should be 4 and not 5. So how do you explain that difference over there?
I'm sorry, I did not get your question. Can you please repeat that?
See, it's the input which determines the output, right?
Yeah.
So
Yeah.
your input was based on standard criteria, the Milan and other criteria. So they predict whatever predictions they give should have been the ones which were given by the AI model as well. How did it give better predictions?
Yeah, so basically, the Liver Transplant Center at Shifa International Hospital has its own criteria. That is, it has different criteria to select HCC patients for liver transplantation. So all the patients who have, like, irrespective of tumor number and tumor size, if they have AFP less than 1,000, then they go for they are selected for liver transplantation. Also it depends on what the MDT team meeting decides. So so basically, not all these patients were within the Milan or UCSF criteria. As we can see that, a significant number of patients in our study were outside the Milan and UCSF criteria. So so that's why even those patients that the Milan criteria said that they should develop recurrence, but they did not develop recurrence on long-term follow-up. And similar goes for the UCSF criteria. So I hope that addresses your question.
Just to an extent, but then you're comparing apples and oranges, right? Because you've got this criteria outside of the standard criteria. And then we should have, positive predictive values, negative predictive values, all that should be in the equation so that we know how reliable a particular test is or a particular result is.
Yeah, so yeah, we did calculate positive predictive values and also the negative predictive value, but I've not included them in this presentation. Hopefully, when this is published, then we plan to add those values in our paper.
Okay, we have one last question.
Okay, okay.
Thank you, Abdullah, for such a nice presentation. So can I ask you, who was the liver transplant surgeon between this time period that you mentioned? Thank you.
Yeah, thank you so much. So a lot of liver transplants of these patients were done by Dr. Faisal Dar, Dr. Hasib, Dr. Nusrat, and Dr. Abubakar Hafiz Bhatti. So yeah. And so one thing is that all of them have like comparable outcomes. Yeah.
Okay, thank you, Dr. Abdullah, for a very nice presentation. So while our judges are, I think, preparing the results, I have a few other awards to give out. So before we move on to the results for this session, I'll move on to Bashir Alawi Award. The objective of this award, we started this award a couple of years back, and this is mainly to acknowledge cancer research which is carried out in Pakistan by researchers, clinicians, scientists from across the country. They are invited to submit their best publications for evaluation by an independent committee composed of scientific experts. And this is the current award would deal with the papers that were published in PubMed Index journals in the year 2023. Bashir Alawi Award was co-founded by Dr. Humayun Bashir, who still is an honorary consultant with us at Shaukat Khanum Memorial Cancer Hospital and Research Center in Lahore, and Professor Abbas Alawi. Dr. Humayun Bashir is a full-time consultant at the moment in nuclear medicine at Kent and Canterbury Hospital in UK. And Professor Alawi, I'm sure quite a few of you would know about him, is a world-renowned physician-scientist and professor of radiology at the University of Pennsylvania in USA. We do have a small video message by Dr. Humayun Bashir's mother. This award is actually in memory of Dr. Humayun Bashir's father, Mr. Ijaz Bashir. So I would like to please play the message by Mrs. Bashir here.
Yeah, Mrs. Bashir.
And to give the award, may I please request Dr. Mansoor Bangash to please come on stage. And the award actually has already been decided by the committee, like I said, and this would go to Dr. Ahsan Rashid from Shaukat Khanum Memorial Cancer Hospital and Research Center at Lahore, tracing the origin of 23 recurrent BRCA1 mutations in Pakistani breast and ovarian cancer patients. Congratulations, Dr. Usman. Okay, we have one more award, and that is a Begum Mir Research Award. And this is basically related to the presentations and publications related to nursing. And this is in memory of late Begum Mir. She had a very strong conviction to provide free healthcare to poor and needy patients. And hence, Mir family, after her death, donated and helped in constructing a nursing teaching block at Shaukat Khanum Memorial Cancer Hospital and Research Center in Lahore. And this is called Begum Mir Building over there. And this award is basically to honor her memories. And this year, in order, the winner of the award, and first of all, I would like to call Professor Saab to please come over on the stage and to give the award. Professor Jas, please.
Yes, sir.
The award this year goes to Ms. Tahira Batul from Shifa College of Nursing in Islamabad. Family caregivers' experiences of caring for cancer patients in tertiary care hospitals, Islamabad, Pakistan. Thank you very much, sir. Okay, we have a few more awards to give out before we move on to the results for the Ahsan Rashid Memorial session. These are for e-posters. There's one. Okay, so this is for the e-posters, and I'll start from the. First of all, I'd request if Dr. Amir, if you could please come on stage. From Shaukat Khanum Memorial Cancer Hospital in Peshawar. He is the head of internal medicine at Peshawar Hospital. And I'll start with the third position award, and this goes to Dr. Sara Saeed from SKM CHNRC Peshawar. Navigating bowel preparations in left-sided colonic resections as day cases in SKM Peshawar, Pakistan. Okay, thank you, Dr. Amir. I would now like to request Dr. Shahid Khattak to please come on stage to give the award for the second position for the e-posters. And this goes to Dr. Dua Amir from Jinnah Sindh Medical University in Karachi. The complexities and uses of AI in laryngological cases. Is she here? Huh? Achha, she's just left. Sorry about that. So why don't you stay and we can let you give the first position award. And this is for Dr. Lalima Shahid, Rahman Medical College, Hayatabad, Peshawar. Knowledge and practices regarding menstrual hygiene management and comparative study of medical and non-medical female students of Peshawar KPK. Congratulations. Thank you, Dr. Shahid. Now I would like to request Dr. Irfan Kabir to please come on stage to give the award. And this is for the free paper video session, Limb Salvage with Mega Prosthesis, Muhammad Zoha Farooq from Shaukat Khanum Memorial Cancer Hospital and Research Center in Lahore. Congratulations. Thank you, Dr. Irfan. Okay, next I would like to request Dr. Maria Kuptia to please come on stage to give away this award. And this is for the free paper day one, and that goes to Dr. Sara Baloch from Shaukat Khanum Memorial Cancer Hospital and Research Center, Peshawar. The usefulness of FDG PET-CT in routine staging of gastric cancer, a retrospective experience from a tertiary care cancer center. Congratulations. Okay, next I would request Dr. Ahsan Wakar to please come on stage to give this award. And this is Dr. Muhammad Awais Khan from, I think from Rahman Medical Institute, Khyber Medical Institute. Okay, please. Classification of non-WNT, non-SHH medulloblastoma into subgroups using prioritized methylation signatures. Thank you, Dr. Ahsan. And for the last award for this free papers, may I request Dr. Arif Jamshed to please come on stage. And this goes to Dr. Yasir Inam, Shaukat Khanum Memorial Cancer Hospital and Research Center in Peshawar, pioneering the fast-forward trial impact retrospective analysis of acute and long-term side effects in breast cancer patients treated with ultra-hypofractionated radiotherapy at a specialized cancer center. Congratulations. All right, before I move on to announce the result, it is my pleasure to inform you and to welcome Mr. Mansoor Ahsan, who's Mr. Ahsan Rashid's son, and he's here for this award, especially in Peshawar. Could I please request you, sir, to come on stage and say a few words?
Assalamualaikum. Thank you so much for having me here. It's a privilege and an honor to be presenting this Ahsan Rashid Memorial Award. You've given a wonderful introduction to my father, so I won't get into that. But my father was a huge believer, and he believed in Shaukat Khanum and for the cause that Shaukat Khanum had. He himself was a cancer patient, and he was treated at Shaukat Khanum, and he received world-class facilities and treatment here. It is again a privilege and an honor, and it's incredible that the work that Shaukat Khanum is doing, and I'm so excited and so happy to see all the research that is being done here. So I say this with a lot of pride, and whoever wins the award, I know if my father was standing here, he would be saying all of you are winners. So well done to all of you who presented the research. Thank you once again.
Why don't you stay on stage, because we have to go. And if I could request Dr. Kashif Sajjad, the chair of the symposium this year, to please come on stage as well. And okay, so we have had some tough decisions to make, and we finally have a winner. So what I'll do is I'll start with the person who came third, so that that person doesn't get an award, but at least we can announce as far as the scores are concerned. So there is a tie for the third position between Dr. Mahanur and Ms. Sidra. For the second position, it's Dr. Chatta. And the winner is okay, it's Mr. Ali Islam from Shaukat Khanum Memorial Cancer Hospital and Research Center, Lahore, Pakistan. Next generation sequencing, unraveling genomic variants relevant to clinical practice. Congratulations. Very well done. Okay, and with this thing, we conclude today's sessions. Thank you all for being here, and congratulations, Peshawar, for such a nice event. And congratulations, the chair and the co-chair. And we look forward to seeing you in Lahore next year, where the chair would be Dr. Usman, inshallah. And We'll announce the co-chair later. Thank you very much.